General practice is always under workload pressures, and there's various times where that seems like it's being transferred to primary care inappropriately from secondary care, and the discussion that happens over it is always tumultuous to say the least. Well, a local area has considered this and basically come up with a consensus of principles of how to tackle the primary and secondary care interface. And in this episode, Andy and myself are going to discuss that document, share our views on it, and basically take us through it. Let's take enhance your primary care and learning. Hello, EGP learners, and welcome to this episode as we're going to be talking about the primary and secondary care interface, particularly led by a document by the Cheshire Merseyside Integrated Care System or something like that I've already forgotten, and basically share what this looks and feels like. How are we doing there, Andy, first of all, though?
Yeah, I'm good, thanks, Gandhi. Really looking forward to having a discussion on this topic. It's one of those interfaces and areas that causes quite a lot of friction for
Hmm.
patients. As we refer up and as care is transferred back down from secondary care to primary care. So it's a place where friction and problems can occur for patients and can cause a lot of frustration for everyone involved in primary care. And I'm sure the secondary care doctors get annoyed with us sometimes as well. So more clarity on that interface is a good thing.
Absolutely. And just to point out that this is something that's always been discussed and talked about in various different aspects, especially in primary care, because often we feel like we're the receiving end of this. But important to recognize that this is a two-way street, in terms of what we're looking at and then sharing and things. There has been previous attempts at looking at this. And so the closest thing I can think of is the BMA's Quality Matters document that looks at workload sharing and that kind of stuff. But there are definitely principles and areas where they've looked at this in more detail as well. But in this episode, we're specifically going to be looking at a document. So let's bring it up on screen. This is by the Cheshire Merseyside Health and Care Partnership, and they call it the Consensus on the Primary and Secondary Care Interface. There we go. What does it look like to you, Andy?
Yeah, so it's a really good document. I mean, really, it's an agreement on the principles under which everyone will operate to give sort of smooth care to patients, essentially. I really commend what they've done because they've got a lot of the relevant stakeholders on board here to go through a process to arrive
Hmm.
at these principles, which I think is what's often missing when people try and put these things in place. I don't know if you
Hmm.
know any more about what process they've gone through to create the document. You may or may not, Gandhi.
So I don't know a huge amount. Important to note that one of our colleagues actually has been talking about this more recently. So those of you who are avid listeners to our channel obviously know that we often talk about Ben Gallen's The General Practice podcast. And on his recent episode, he had Dr. Jonathan Griffiths, who's also a friend of the channel and stuff, who is instrumental in supporting this in terms of his role and stuff and advocating for it. And in terms of, they've talked about this in more detail, how they kind of created it and that kind of stuff. So definitely listen to their podcast, and the links for that down in the description of the video and stuff, so you can track across to that and things. But as you mentioned, that they have worked collaboratively with various organisations. Important for me to point out, I guess, is they've also included the local medical committee, and it's endorsed by the local RCGP faculty as well, which is interesting.
Yeah, I was interested to see that the RCGP, often the local faculties are sort of left out of kind of local discussion and decision making processes. So it's really interesting and nice to see them involved. One group that's not there is kind of Health Watch or Patients. I don't know whether that's directly relevant, but I thought that it would have been interesting to involve some patient representation in it. I
Mm,
don't know what if that would have added much, but that would be very much in the spirit and direction of what we're being encouraged to do.
yep. Question of whether they're already included in one of those other provider forums and stuff that, obviously we don't know the makeup and stuff, but absolutely it'd be useful to have patients involved in that discussion. And patients are at the center of this in terms of what it looks like. The initial part is the foreword, and this basically talks a brief amount about what's happened and how it's been developed, and obviously signed by their medical director of their integrated care board, which is what is going to be taking over healthcare in various different areas from next week,
Mhm.
technically, because they come into live on the 1st of July 2020. Yeah, it's a standard kind of forward and stuff, isn't it, Andy?
Yeah, the thing that I just noted, which I think is important, is he's saying, "Oh, I encourage you to share this with your colleagues." So I think this is written very much for perhaps an audience of leaders within the system or heads of department. And I was thinking as I read this, I thought, well, this really kind of fails or succeeds on whether or not it's implemented, whether or not
Yeah.
it's adopted. And he's wise to that in the forward. It's fine
Hmm.
for the top leadership to agree on these principles, but
Yeah.
unless everybody in the system has seen the document, is aware of the principles, and feels supported to apply them,
Hmm.
it's not going to do anything at all. But he
No,
seems wise to that, so hopefully they'll implementation will be good.
I think Liz Hare's comment exemplifies one of the reasons why it can be challenging. We talked about the discussions, and she says, "I, it's a bit of a bum fight at the moment." So definitely loving the Yorkshire twang there and stuff, but absolutely loving that comment.
It is. Can I jump on the at the moment bit? Because I think this interface between primary and secondary care is particularly strained at the moment as we're
Yeah.
dealing with the NHS backlog. There are patients sat, waiting for intervention in secondary care. And, my experience of that as a GP is that they're not always being communicated with effectively by the secondary care teams whose list
Mhm.
they're on. And they keep asking us, what's going on? Where am I on the list? And sometimes we have to ask the question for them up the system, and it all just wastes time. So getting that interface right, particularly in times of stress and pressure like now, will be really, really helpful.
Absolutely. So let's have a look at the document in a little bit more detail. So if we scroll down, Andy, and we're going to talk
Mhm.
about basically there's the initial part it talks about, but it's split into three sections. So this is split into sections for both sides of the table, so primary and secondary care to be aware of. Then it's got primary care, and then it's got secondary care. So let's look at the principles for all, which is the first section. There's a fair few points in here, but what I love, absolutely love about this one is it talks about the key principle, which is absolutely respect. So it talks about treating all colleagues with respect first and foremost. Absolutely essential. And I will admit I've been guilty of not doing this sometimes as well. So I think it's really
Oh,
important.
goodness me, Gandhi. Surely not.
Well, you know what? And I definitely think there are going to be many GPs that can put themselves into this situation. When you're at the end of a long day and you've got a letter that is effectively, from your perspective, dumping a load of work onto you, sometimes the emotion takes over. And one of the things I often tell many people when it comes to social media posts, never post when you're angry. Well, also never write a letter when you're angry. Take some time to and yeah, I've had a 10-year plus career in general practice, Andy. I'm not going to say I'm perfect at the start of it, but
Yeah.
definitely in the earlier parts of my career, I probably was a little bit more verbose than I should have been and stuff. So have learnt many lessons over that time, and absolutely respect is one of them.
Yeah, absolutely. And I think, and often it's about what we say in front of patients and how we react to things in
Mhm,
front of patients, and we can, directly or indirectly undermine our colleagues, and I'm sure secondary care do that about GPs as well. That's something I've encountered once or twice, at
mhm.
least. Um, but yeah, absolutely, respect goes almost feels like it goes without saying, but it you have to say it, and it is
Yeah.
vitally important.
And what I think, like I said, is important is the first thing that comes up. And then the second thing, which is equally as important, but something has to come first and something has to come second. And that is remember to keep the patient at the center of everything that you do. Kind of seems common sense, doesn't it, Andy?
Yeah, absolutely. And there's no further text beyond it because it's just so important and it stands on its own. I
Mhm.
guess. So yeah, carry on walking us through it, Gandhi. So I'm wondering
Yeah.
if we're going to encounter anything that's too controversial. Go on.
Well, interestingly, I think you could stop after number 3, to be honest. The rest of the document, but it basically is based on this. Do what you can do when you can do it, or as they say, there is an underlying principle that clinicians should seek to undertake any required actions themselves without asking others or services to do it for them. So basically, if you can do it yourself. Don't pass it on. What do
Yeah,
you think of that,
absolutely.
Andy?
Yeah, absolutely. And obviously, it then says, they obviously do within the limits of your capabilities and your team's capabilities. Obviously, we're referring things up for things that we can't do.
Mhm.
And they'll be asking us to do things in the community that they can't do because they need to occur in the community. But yeah, it's a great principle. But yeah, but they do flesh it out with further principles. And the next one is obviously important. Whoever requests the test, it's their responsibility to look for and action the results. These feel like very basic things. I guess they have been drawn from other documents, like
Mhm.
the BMA guidance and good medical practice from the GMC and so forth. But it's worth putting them all together. Any more to say
Well,
on that,
I think it's
really?
important that this particular one would resolve probably a good proportion of the number of issues that GP and GP practice in particular feel when it comes to the primary secondary care interface and communication issues. It's simply general practice are often asked to take on responsibility for the investigations of others. And actually, majority of the time, that is inappropriate to do so because actually GMC guidance is very clear. If you initiate a test, it is your responsibility to follow it up. It's not your responsibility to pass that responsibility to somebody else. And now there are various situations where that may be appropriate. Not saying it can never happen. And there are absolutely some times where it's sensible to do so, but that is in the absolute minority. The
Mm,
majority of these things, those should be held by the person requesting the test. So they often think you and I probably both get is a patient has a scan, go back to your GP to get the results of the scan. If I've not initiated it, I'm not even going to get the results in general practice. I'm going to get the results once you tell me what the results are. So that is completely inappropriate transfer of work. And absolutely, this is one of the key things it mentions. And if that one thing was fixed, I think a lot of the angst that we see in primary secondary care interface aspects of things would be resolved. What
Yeah,
do you
and a lot
think?
of confusion for patients as well. I mean, I don't, I encounter that scenario less than I used to. But what I do encounter a lot is a patient has a scan or a test in secondary care, and they don't know what's going to happen with the
Yeah.
results, and consequently, they think that their GP will give them the results. So they ask us about the results. We don't know. They don't come to us because they're going to the
Mhm.
hospital consultant or team that requests them, and we have to redirect the patient. It's all just very, very confusing, and it wastes time in primary care. So if secretary care actually tell them how they're going to get their results, and I'm sure they do in many instances, but often they don't. But
It's
that would just be
really
really helpful.
interesting you say that, Andy, because guess what the next principle is? In short, robust systems are
There
in
we go.
place. The patients receive results, investigations, they understand what's going to happen. So basically keeping them informed.
Oh, perfect. I'm prophetic. There we go. Um, yeah, because it's just so important, and just stops all of that confusion that is happening. So that
Mhm.
maybe is something that isn't going without saying now, and that's
Yeah.
an area for genuine improvement, I think. Yeah.
And it also blends into the second part about keeping them fully informed of their care. Now, let's be clear, secondary care services have been under significant and astronomical strain over the COVID period, and the backlog is causing so many challenges across the various different areas. So, therefore, keeping patients informed, unfortunately, seems to have gone a bit lower down the list in terms of trying to deal with things. But actually communication is probably the key to resolve a lot of the challenges many people face and stuff. So, I have many patients come and see me after they've been seen in clinics and stuff, and they say, "Well, I don't know when I'm gonna be seen." They said they'll see me at some point. Well, what does some point mean? Does that mean next week? Does that mean next year? Does that mean, you know, whenever I decide to contact them? One of the classic ones I find really frustrating is the open clinic perspective. So clinicians often think they know what open clinic means. Patient can come back, they have an open appointment to come back in clinic. You and I probably know that that often means if they don't contact within 6 months, they're discharged.
Mm. Yeah,
So, and
absolutely.
it's gonna be different in different areas, but it's that concept of communication in terms of their forward care that needs to be a lot clearer for patients and stuff, and does need to be outlined because patients don't often know, and actually half the time clinicians don't know as well, so
Yeah,
yes. Next up.
absolutely. So next, I mean, so I think keeping patients fully informed, which I think is very similar to the robust systems for results investigations and understand what's going to happen. So yeah, I mean that's very sensible. I think related to the point above. Consider picking up the phone to speak to colleagues if in doubt. I think organisations need to facilitate this, don't they, as well?
Mhm.
Because it's very easy to say, and we'd all love to do it. And I think we used to do it a lot more than we perhaps have done
Yep.
recently, just because we've had a sort of a shift towards advice and guidance, and using written methods rather than the telephone, and also it just becomes increasingly difficult to get hold of someone, doesn't it, on the telephone? um, People don't answer, you have to leave messages. You
Mhm.
have to be ready to speak at the same time as other people. So it's interesting they've singled out the telephone, actually, because there's other ways of communicating that may be more efficient, I guess. But
Mm,
so
I don't
in
know.
terms of, non-real time communication, Gandhi, I'm talking about, because if you think when you try and you need to be free at the same time as the renal consultant,
Yeah,
like that's difficult.
it is
But maybe
difficult.
that needs to happen for very important particular conversations. I don't know.
Potentially. I think it's also important to recognize those other methods of communication sometimes can also be the cause of the angst itself. So, the concept of sending a electronic notification, a task, an email, whatever, it's that whole fire and forget aspect of stuff that could potentially occurs with it. It's the transfer of responsibility. Again, I've told you what I want you to do. It's now your responsibility to sort it and deal with it. It's not mine because we're not having that live discussion. Whereas the live discussion allows for tone, which is one of the things we often forget. Tone is really hard to convey in an electronic format, especially when you're trying to be concise, which many people are because of time pressures and stuff. So it's important to recognize that key aspect of stuff and things. So yeah, yeah, important to do. Thank you, Zach, for reminding us and stuff. So we have zoomed in a little bit, and I love the photograph there in terms of the bunny.
Oh,
It
it's the
does.
hair.
I think
Alice in
many of it,
Wonderland.
yeah, the
Mm.
hair. Many of us probably do feel in general practice and stuff and things, but and across the entire NHS as well.
Yeah. Consider
Next.
process for waiting well for
Mhm.
patients referred to secondary care. What are they talking about here, Gandhi?
So waiting well, where have we got to? Yeah, so waiting well. So this is when clinicians, particularly in general practice or other services, refer a patient onto another service, and managing them in that interim period. So what happens? Because often, and I think sometimes in general practice we're guilty of this, we refer a patient to a secondary care service and we say, well, you can be seen and dealt with, and that's it. But we're dealing with a backlog situation. We're dealing with a situation where potentially that outpatient appointment may not be for a few months. In some situations, it may not even be for a year or so. So what happens in that interim period? And often that's one of the reasons why patients come back to us, because they're on the waiting list. Well, what does that mean, and how do you manage their healthcare needs in the meantime and stuff? So I think this is a absolutely dual point that we need to be aware of and things.
Yeah, I'm beginning to see that actually maybe additional systems. Yeah, people talk about patient access to their
Mhm.
record. Access to an indication or a calendar of when appointments are going to happen. I know there's been efforts locally in Nottingham to try and get this in place and integrate it with
Mhm.
NHS App for Patient. But you can see how actually it's not necessarily just about services doing things in the same way that they've been doing them in the past. Maybe there's an opportunity for bigger thinking to make sure that documents like this can be properly implemented.
Yeah, and I think it's also explaining the expectations of the services as well. So I know in our local area, for example, you and I can no longer directly refer a patient for surgery for an orthopedic issue. They have to go through what's called our Mosaic or MSK-based service. And actually, typically the first clinician they'll have in contact with that is a physiotherapist. I've had several patients where they won't go to that appointment because it says they're going to see a physio, and in their heads they don't want to see a physio. They want to see a doctor because they want to have surgery, and actually it's explaining the process, that the reason why that's happening, because there's an initial assessment that happens before they get on to the next step. Now, it's not something we've introduced, that's the system, but you need to explain that system to the patients and managing their expectations in the interim. Otherwise, what happens if they don't go? They get discharged. I'm going to talk about that in a second. And then you have to restart the process. But unfortunately, then they're way back at the beginning of the queue again.
Yeah, absolutely. Yeah, like many people, I get ahead of that now and just say, look, it's going to be probably a physio first, but that's
Mhm.
part of the process, etc., etc. Absolutely. The clinician who wishes to prescribe medication for the patient should undertake appropriate pre-treatment assessment and counselling. Again, this sort of goes without saying, doesn't it? But I guess
Mhm.
there's an issue of commencing medicines in secondary care and then
Yeah.
asking the GP to carry on. And is the GP confident that all of those assessments and that information that needs to be conveyed to the patient
Yeah.
has happened or not? And I guess this just clarifies it that it's the person starting it who is responsible, which is really helpful.
And I think again, this is one of those situations where we're trying to be time pressure, because we are time pressure, sorry, and we're trying to be concise and effective in our documentation and communication, that this step is sometimes forgotten. And particularly for certain medications, there are relevant things that need to be ensured that they've been discussed for making sure that medication continues. So I'm thinking of things like, for example, the DOACs, medications that have real benefit when they're used for the right reasons, but have significant risks if patients are aware of them, and they need to be aware that certain things have happened. And I don't want to put my name on a prescription unless I feel that patient's been suitably educated in terms of how to manage those medications and stuff. And if that's not communicated to me, then I'm going to either have to say, no, you do it, or bring that patient in for another consultation just to make sure that that safety element has happened, because we particularly do live in a medical legal world where that is a relevant factor, as well as patient safety, making sure they actually know what to do with it. So
Yeah.
there are many other examples, but that's one of the key ones I often find is neglected in some ways, because that information is not shared, and it may have been that discussion has happened. But if I don't know it's happened, it impacts the safety of that prescription and stuff. So that's why it's really important that actually that counseling has happened, and more importantly, the documentation of that being shared.
Yeah, and this is where quite simple measures like, having standard blocks of text that can go into patient letters that just, the discussion's happened. You don't have to
Mhm.
dictate all of that discussion, just maybe ask the secretary to pop in the relevant
Yeah.
blocks, indicate it's happened. And then, yeah, the patient's copied into that as well. So they have a copy of that discussion and that information for future reference. So, yeah, hopefully this prompts people to just think a little bit differently about their
Mhm.
system, put some really simple, measures in place to meet them.
So next up is try not to commit individuals or teams to other particular actions and stuff. I think this is really important. And again, this is both sides of the coin. This is not just, secondary care needs to do this. Is absolutely primary care needs to do this as well. There is no point referring a patient saying, yep, you're going to get a scan. Well, actually, the patient may not get a scan. They may get something else. And then are you creating conflict and issues in terms of that patient journey because you've told them you're going to get a scan? Well, actually, there may be a different reason why that's not happening, and stuff. So important to be aware both sides of the coin. This needs to be discussed. And absolutely, from secondary care's perspective, please do not tell the patient they're going to get a referral to a particular specialist just because you're not sure what it is. Actually, majority of things we can handle in general practice, and we may do, and we may have systems that mean that we should do as well. So therefore, preloading a patient expectation, they're going to be seen by another specialty service, or they're going to have a specific type of investigation. Yeah, don't do that, please. It makes problems. Thank
Yeah,
you.
emergency department contacts are often where this seems to happen, and often I'm not quite sure what's been said by the emergency department practitioner to the patient, and I do
Yep.
wonder if sometimes the patient, something is said, the patient feels they've heard something else, and that's what they tell us. It's
Yep.
less common for these things to be asked for in emergency department discharges, partly because there's very little information often in the
Mhm.
well, just only essential information is conveyed, isn't it? It's not an information-rich document. So sometimes you
Yep.
don't know. But the patient says something's been said, and then there's nothing documented about what's actually said, and that's where a lot of
Yep.
confusion occurs. So, yeah, communicate effectively, and also don't commit
And the
other.
flip side of that, if you have specifically stated that patient should have something, explain the reason why in the documentation. If you're committing somebody else to doing something, you need to be absolutely crystal clear why you're suggesting that and things, because
Yeah,
actually we may not be aware of that information. And again, it goes two ways, primary and secondary care. This is it for everybody and stuff.
yeah.
But we're not.
Risks, confusion, and patient dissatisfaction lies in those grey areas, don't they? So
Mhm.
let's just all be clear with each other about the communication. So principles for primary care. So this is us. So I guess this is what our primary care colleagues have agreed to and felt was appropriate and have been asked to agree to in the
Mhm.
process of putting together this document. So let's see.
So first thing is, I can summarize this in be very clear in your ask. So when you are referring a patient, when you're suggesting that they need interactions with the secondary care clinicians and things, then you need to be clear. And I would absolutely agree with this. One of the things, so GP trainer, I help train our next generation of general practitioners and stuff. And I think absolutely one of the things I enforce to, in terms of their training is whenever you do a referral, you need to be very clear. Why am I referring this patient? What am I asking a question about? What is the key things? And potentially, I even explain what my expectations might be based off the information I've been presented with and what I've told the patient that they may need to expect and stuff. And I think that's important. And I know we talked earlier about don't put expectations on other services, but then I'm at least giving a picture to the other side why I'm doing this. And I think that really needs to happen. And especially when it comes to things like patient expectations, sharing that information. So if the patient's coming with the expectation of a scan, actually that needs to be shared because that's their expectation, and you're helping explain the process of why we've got to this point. What do you think, Andy?
Yeah, I mean, it sounds like they're sort of asking us to tick all of the general boxes that I would hope we would be aspiring to tick when we're making a referral, really. So I think it goes without saying. But I know that often, GPs are writing referral letters, at great pace.
Hmm.
It can be difficult when you're rushed to get all of these things in there, I suppose. But just knowing that these are what the secondary care colleagues actually feel are really, really important in terms of a minimum standard for a referral is actually helpful to see that there.
Yep.
So yeah, I think it's very
Yeah.
sensible. It
So,
needs
so
to
for
be.
example, if you're the clinician that's saying this patient has a PR bleed, please do the needful. That is not helpful for
Yeah.
anybody. Let's be clear on that point. And people are probably thinking, "Oh, I would never do that." I guarantee you, there's a clinician out there that has done that in the past. I know
Yeah, yeah. It
clinicians.
feels old fashioned, doesn't it? But it's probably still happening. Yeah.
Yep, absolutely.
Uh, yeah, when referring to secondary care, please ensure appropriate primary care assessments have been made. So I
Mhm.
suppose um, also what's important is to kind of to know what secondary care feel is appropriate to do
Yeah.
pre-referral, and that's where local pathways and guidance come in. And we're quite fortunate, I think, in Nottingham that there's been a lot of work put in to make that to have those discussions with secondary care, make that information available through GPs through IT systems, and I really appreciate that. Yeah, any other thoughts?
So I think this is actually likely to be the most controversial part of it. And the reason why I say this is some places have taken this with a view for sharing information. Some places have taken this as a pre-referral requirement. If you haven't done it, you can't refer the patient. And that's the part I think we need to be cautious of. So there may be an absolute reason why certain things have to happen and should happen. So, for example, if you're referring a patient with query, renal failure, you ideally should have done a kidney function and probably done an ACR and various other checks and stuff before you refer the patient on to understand the situation of that particular patient, so you've got a complete picture and stuff. And apologies for those non-medical people that are watching this part thinking, what the hell is he talking about? But the clinicians out there will understand, hopefully. Um, but there's a difference between actually, I need to refer this patient because I've got concerns, but I haven't managed to arrange everything yet, and I'm doing it, versus you're not referring the patient until you've done it. And we've seen many examples, unfortunately, where that's taken as a stick method or as a gateway method or a tick
Mhm.
box or whatever and stuff. And actually, I think when we're blending into that, that's where it's negative. But on the flip side, I completely understand the secondary care perspective that they need certain pieces of information to help assess where to place this patient in the vast numbers that they are getting, and also the appropriateness of it. So the classic one I find is the HbA1c. So the patient with diabetes, their level of diabetic control. Actually, if they're being considered for certain types of treatments, especially things like surgery, they need to have fairly good control in order to make that less risky a procedure to consider. Because if not, then that needs managing. And this blends into the one just one below this, which is about control of long-term conditions. So I don't know if you want to share that one a little bit just there, Andy. Yeah, when referring with the expectation the operative procedure may be ultimately required, please consider optimizing long-term conditions. So, if you've got a patient with a really poorly controlled HbA1c, their risk factors for surgery is so much higher compared to if it's not. So, actually, do you need to get a handle on that as you're still managing their healthcare and you're still trying to manage their other health issues, but that needs to be well controlled, and that is general practice responsibility to do. Similarly, patients with COPD, actually, if they are, horrifically poorly controlled with their COPD, but you're thinking about surgery, actually putting them under a general anesthetic is probably the worst thing you could do, irrespective of what the other health issue is. So you need to take that into account and have that relatively well controlled. I think those parts sometimes, different areas take different views of how that needs to be looked at, and I think there's a definite complexity between making it an absolute tick box versus this does need to be considered. And it is our responsibility in some ways to make sure it's sensible and appropriate. What
Yeah.
do you think, Andy?
Yeah, and I agree with everything you've said, and I think you're sort of circling an issue which is around allowing some flexibility in terms of things getting through as referrals. I guess what I'm saying is a problem I sometimes encounter is it feels like some of these referrals are vetted by perhaps non-clinical or very junior clinical
Mhm.
people. And there might be a good reason why somebody hasn't had one particular thing done, or
Yep.
the rest of the referral might be so compelling that they clearly need to see the speciality, but they've just not had their fit test done because they just haven't been returning the sample or something, and
Mhm.
that can result in a referral being bounced back and delaying time. So I think, yeah, we just need to make sure these are principles. They're not necessarily guidelines. They're
Mhm.
certainly not hard criteria. And we need to make sure that there's enough flexibility within the system to allow uh, people to get things through that are not typical. So
Yeah.
yeah, just wanted to make that point, which I
I'm
think
gonna
we
go give a really quick shout out to Parody at parody_RCGP Twitter handle, and someone that many GP clinicians probably aware of and stuff. But the common issue that raised by that Twitter account, so it's an anonymous account and stuff. But really interesting that it raises the issue of who's vetting the referrals, because of if it's generally non-clinician based, they may not appreciate some of the reasons why certain things are not able to be done, and it goes, a computer says no. Just before we go on to this part, Andy, do you mind just scrolling up? So we did skip one, which is
sorry.
actually really relevant. So it's when referring to secondary care, please clearly communicate to the patient who you're referring to and what to expect. Again, we talked about this earlier in terms of potentially explaining pathways, but also why you're referring them to one specialty in consideration to other ones. And sometimes this does happen, that actually, a patient thinks they're going to, say, for example, neurology, but actually we're sending them to orthopedics because their symptoms match up more towards that side of things, and vice versa, different specialities and compared to what the patient may originally been expecting and things, and why it's different, because actually that's a more relevant pathway to manage their healthcare issue. So important to be aware of that, and also how to approach that. This is possibly something where, automated systems in practice using, better communication, leaflets in different languages, easy read, that kind of stuff really can help and stuff, and make that patient journey more effective, rather than making it muddy and stuff.
Yep, I agree entirely. Yeah, it's just an issue. Sometimes it arises around debriefs. Sometimes I think
Mhm.
where the plan can change, and it's just making sure that's definitely communicated
Yeah.
to the patient. That's just one example of how these things can sometimes go awry, even with the best of intentions. So the next section is
Principles for
principles
secondary care.
secondary
So
care.
this is for our secondary care guys. Now, obviously, me and Andy are both GPs. We're probably going to have a slightly biased view to the primary care perspective, and absolutely happy for anyone to comment and challenge on these parts. But these are the principles they've recommended in discussion with secondary care colleagues that should be happening from their perspective and stuff. So, first of all, big one for many areas. What do you think,
Yeah,
Andy?
yeah, ensure timely communication to the GP following patient contacts. Um, yeah, it's one of those things that's quite frustrating, isn't it? Often the patient comes back telling you what the plan is and things that the consultant, has written to you
Hmm.
to do before you've got the letter. That still sadly happens, and I can see, having worked within hospitals before, and understanding that it's not always as simple as you might think to get a letter
Hmm.
dictated and out in a timely fashion. But goodness me, if that could be sped up, that would be really, really helpful. But what are
Absolutely.
your initial thoughts?
Definitely agree. I think there needs to be an understanding of the timeframes that these informations are shared. So, if your clinic appointment letter is not going to come to the GP for 2 weeks, asking the patient to go get something to start within those 2 weeks is completely pointless because the GP won't have a clue. And sometimes patients don't remember because we know that patients do not remember everything that's talked about in their consultations. There's tons and tons and tons of evidence that matches that up. More importantly, I'm going to say this actually tracks onto another issue, which is not mentioned in the principles and actually should be, in my view. The patient should not be the communication vehicle for information. So it alludes to this in some aspects, but actually, and there's a good reason for that, because of the fact that patients may not remember everything that's discussed, may not remember the names, the reasons, or the indications and stuff, because it can be confusing. Medicine is its whole other language completely. So actually, the patient should never be the communication vehicle for medical information between specialists and stuff. And remembering, general practice is a specialism; it's a generalist specialism. But that should never happen, and it plays both ways. I'm going to say this is a principle for both sides. So GPs should not be telling the patients when you go to clinic, you need to make sure that you ask about this, this, and this. If you're telling the patient that, you also need to be sending a communication to the clinic to say, I've explained to the patient, do this, this, and this, because that is an inappropriate way to manage things. Similarly, secondary care, you shouldn't be telling them, go see your GP to get X, Y, and Z, because actually, unless you're documenting that, more than likely the practice is going to turn around and say, uh, we're not sure that's appropriate. We either need to have a consultation with you first and stick into the appointment system, whatever that may be, or no.
Yeah, absolutely, and even more widely, other other parts of primary care are guilty of this as well. I just think about
Mhm.
ourselves, yeah, definitely, and our nursing teams, and also the carers within a care home perhaps should not be the people communicating, required changes to medications and
Absolutely.
management. The teams should write to the general practitioner themselves, or send them a task within the relevant clinical system.
Mhm.
Yeah, almost feels like it should go without saying, but you're right, it actually happens so much that it probably needs stating.
Yep.
Yeah.
When you are communicating information, it needs to be clear. What is the actual plan? Just saying, please do the needful. Please, monitor user needs. It mentions this one, so please monitor patient user needs. What on earth does that mean? Does that mean you need it done daily? In which case, they need to be in hospital. I've had that. Please monitor this patient's user needs on a daily basis. Sorry, general practice is not designed to do that. Whereas, check it once every 3 months. Okay, absolutely. More than happy to keep an eye on things in that kind of situation and stuff, as long as it's agreed in terms of various other aspects like shared care protocols, that kind of stuff and things as well. So, it's important to be clear in terms of the information that's needed, but absolutely that aspect of do not let the patient be the communication vehicle. I'm going to keep saying this one.
So, yeah, avoid asking general practice to organize specialist tests.
Yep.
I mean, I guess, if you're seeing someone and you think that something is required, I mean, almost anything really, I guess you should organize
Hmm.
it, I suppose, but particularly specialist things that we might not have the ability to organize at all.
Hmm.
I've been asked to do things, particularly certain types of imaging, that actually we're not able to organize or request,
Yep.
flat out in general practice in our area. And that creates all sorts of problems. We have to write back, tell them to organize it if they think it's necessary, and that just creates all
Hmm.
sorts of delays and confusion for the patients. Or they sometimes don't believe that we can't organize them and think that we're being obstructive. So
Hmm.
definitely quite a difficult area. Um, absolutely, yeah. Any further thoughts?
So similar to that, like you said, it's just making sure that you're not asking us to do. I mean, it comes back to one of those earlier things. If you can do it, why are you asking somebody else to do it on your behalf? Actually, but more importantly, if you can't do it, well, what is the route that that needs to then happen through? So, like you say, often we get asked, I get questions about doing an MRI of a patient's neck. Well, actually, unfortunately, I can't request an MRI of a patient's neck directly. I have to refer them to a specialty because that's the current mechanism of doing so. So it's a complete waste of the patient journey and time. Because particularly if I'm having to wait 4, 6 weeks for that letter to come, I'm not going to get it. I don't know why they want it, so I'm not going to do it until I get a communication to explain that. Then I get it, and I'm like, well, I can't do that. I have to figure out how to explain that to the patient. I have to then manage the expectations of the patient and also navigate which is the best route to have that done, especially. And then what does that mean moving forward in terms of the patient's care? Well, there's been a massive delay when it didn't need to happen.
So the next one,
Hmm.
this one will be really, really helpful actually. And, I remember writing sick notes when I was in hospital, particularly when I
Hmm.
worked in surgery. I used to do the 6, 8 week sick notes, following
Yep.
surgery. But then when I came to general practice, I guess you don't see what's already done, I suppose.
Hmm.
So I'm sure large parts of secondary care, are like me when I worked in surgical department and do this.
Hmm.
But nonetheless, some patients come to us and say, "I've had a surgery, or I've had an acute admission, and they said I needed a sick note and to see the GP for it." And it's really frustrating and it wastes time, doesn't it? So
Hmm.
it's good to see a principle in place that should mean that that doesn't happen.
I think there's various different aspects of this to consider, like you say, Andy. So there's first of all, considering does this patient need time off work? And actually, that is the responsibility of every clinician that sees a patient in their individual setting. How is their health impacting all of their well-being, including their working way and stuff? So actually, first of all, asking the question, you know, are you working? How is this impacting your ability to work in terms of what you're currently here with in front of me for? And then questioning, does that patient need time off to manage that, or modified reasons to help support them continue working and stuff. Second question then is providing that note. And I think one of the key areas where this probably comes up to play is actually in A&E, more of an issue. So as one of the places. So, if a patient's seen with, for example, a broken arm in A&E, yeah, they're probably not going to be able to do their job straight away. Talking at least a short period of time when they're not going to be able to do what they would normally be able to do. So, whose responsibility is that to manage? Well, actually, it is by definition, it's the any clinician's responsibility to sort that out. It's not their responsibility to pass that back to general practice because realistically, that's not going to fix itself in a week, which is what they can self-certify for. So, actually, all any departments should have med threes in them in their organisation. If they don't, actually, it's a neglectful duty of that organisation to provide that paperwork and documentation to their clinicians to support the patients.
Yeah.
And I'm going to use that word appropriately. It is a neglectful duty of the organisation, not the clinicians, the organisation to provide that communication because that's part of their healthcare. Second part is like what you mentioned, when a patient has a surgery process, in terms of them having the appropriate time off, not just say, "Oh, we're going to give you 2 weeks because that's what we always do," and actually, but we're telling you can be off for 3 months, so go see your GP for the extension of that. A complete waste of time for everybody involved. It's a waste of time for the patient. It's a waste of time for the general practice surgeon then has to manage that, and actually, even for the clinicians that have given that advice, you're giving incorrect, inappropriate medical advice to a patient.
Mm. Yeah. I was just thinking there's been recent proposals to extend the ability to sign sick notes to
Yep,
other members of the healthcare team, which I think will be really helpful
from
because
next
actually,
week.
yeah, certain parts of emergency departments can operate, with very little medical input, certainly in
Mhm,
minors and so forth, can be quite nurse practitioner, physician associate kind of, driven. And similarly, minor injury units, walk-in centres, I can see that being helpful for them in terms of providing sick notes for illness.
mm,
So I think the future's bright on that one. I just noticed we had a comment from Vij could, might be worth just bringing up.
mhm.
I believe share care just means to dump more work on primary care. There is no remuneration for it, or is there? Question mark. I think it depends. I think a lot of work comes without an enhanced, service contract to support the delivery of it, and comes informally. If not, proves my point. More work, no funding. I think actually, I can't see me on the screen, so I'll remove the comment there.
Mm,
Yeah, a lot of the conversation around moving care to the community and closer to the patient, I think sometimes I worry might fall victim to the same problem here as well.
yeah,
So my immediate question is, and the funding's coming too, right?
yeah,
To provide it.
absolutely.
Just to
And that may
confirm
and that
that.
does happen in some areas, may not happen in all areas, and that often may not be commensurate to the amount of work involved as well, so important to recognise that.
Mm.
Gonna crack on though, so we're gonna go into the next section, so which is, prescribe, immediately prescribing what is required from outpatients, then please prescribe it. So, for example, if you're saying a patient needs a medication to start pretty much immediately or urgently, then that should be a prescription that's given to the patient in the outpatient appointments and not given a prescription for them to again say, oh, and go get your GP to transfer this to a community prescription so you can go get it rather than having to wait in our pharmacies. Any clinician doing that,
Yeah.
not good. That was meant to be on the back of the hand. Sorry, not the
Yeah.
front of the hand.
Yeah, a
I
round
just
of applause.
realised I did that the wrong way round.
Yeah, FP10s, green prescriptions in hospitals would be really, really helpful,
Mhm,
as well. The patients have more choice about where to get it from. They often don't understand that they have to go to the hospital pharmacy if they're prescribed something
mhm.
from within the hospital.
But
Um,
especially if you
discharge
are asking the patient to start the medication immediately and it takes 3 to 4 weeks for your communication to get to GP. Hello, that's the issue.
So discharge medications for longer term medication should cover an initial period of 14 days or longer as locally agreed. I mean, just very obvious why that's
Yeah.
important. If that correspondence saying what their discharge medication is going to be isn't immediately with the GP, if the GP surgery, can't immediately process that to provide medications, then the
Mhm.
patient's going to run out. So giving a 14-day supply just is common
Especially for those
sense.
complex ones where patients may need additional tools like the DOS boxes and that kind of stuff. They take time to organize, to make the changes, and more importantly, for the pharmacist to dispense as well. Setting up a 20 patient medication list into a DOS box is not something that can happen in 5 minutes. It takes a lot of time to generate that and stuff. And they talk then about using discharge medicine service that's nationally commissioned from community pharmacies. So more pharmacies are now integrating themselves with hospital-based discharge things. So they sometimes have that information in a similar time frame to us to support the patients, understanding that those can be really useful and things to help out and stuff.
Absolutely. So just moving through, we're
So
recommending
when
ongoing. Go on.
Yeah, when recommending ongoing prescribing from the GP, please check locally the agreed prescribing formulary first. Yeah,
Yes.
the,
Yeah.
the,
Is it on the
we've got to
formulary?
do this.
Can we provide it? Is it a red drug,
Yeah,
which we can't actually prescribe in primary care? I think hospital departments are getting much, much better at that. But
mhm,
and often it's where people are transferred between different localities where that can be
yeah,
that might have slightly different red drugs can be a bit of an issue. But yes, check
yeah.
that we can do what you're suggesting.
So, if any of our secondary care colleagues are listening or watching to this, I would highly recommend that you check the local prescribing formulary, particularly for your specialty and the drugs that you would commonly recommend, and make sure you are recommending and suggesting the ones that are on that formulary. Because if you're not, you are likely to get a letter from the GP or practice or team basically saying that we can't prescribe that because it's not appropriate. And I've had several situations where that happens and continues to happen. But particularly when you move into a new department, new area, common thing to get wrong, and actually that's causing more problems.
Yeah. So I think we can be fairly quick fire with some of these other ones.
Yep.
But some of them are really, really good ones coming up. But yeah, if you're talking about smoking cessation, do the referral yourself. Don't ask
Mhm.
primary care to refer to smoking cessation services. That goes without saying.
I
I
wonder if
think
that's more of a local one for the Cheshire and Merseyside area, but, in terms of I'd probably patch this across to, using the local kind of, community services more effectively. So if you are trying to extrapolate this to different areas, you may have community-based services that are sensible for you to patch patients directly into rather than necessarily sending them to the GP to do that workload for you again. Yeah.
absolutely. Recommend some follow up for patients who self discharge. I think this is really, really helpful. I think
Mhm.
sometimes hospital departments, if the patient self discharges, they just kind of stop all processes there, or this is my
Yeah.
impression from my perspective in primary care. And often, actually, that patient, it might be important to communicate certain things that have happened during their contact with them, with the department. It might be important. It would be helpful to have a management
Mhm.
plan or some suggestions. Sometimes you just don't get anything apart from self-discharged, which
Yeah,
is not
and it's
very
important to
helpful.
recognise that there are sometimes valid reasons why patients have to leave the hospital environment. Me and you work in a fairly deprived area with lots of single parent families. If they've got kids that they have to look after and they've got nobody else to do that job, they have, they feel their responsibility outweighs their own individual health and advice over what might happen. And therefore, as a result of that, they do self-discharge themselves. But actually, what happens if that happens again? What do we need to do? How do we need to manage that? Is this just because of inefficiencies in the system that's creating the system rather than necessarily down to patients making inappropriate choices because of the system itself? I don't know. And then we talk about ensure any DNAs are not automatically discharged without clinical review. Oh, hell yeah, please. This would save so much angst and bureaucracy in general practice in terms of patients having to be re-referred just because they've been discharged inappropriately by clinics because of communication issues or because of non-attendance, which sometimes is absolutely the patient's responsibility to bear, but also the clinics have a responsibility here. Numerous times I've had many patients who have had their appointments changed at the last minute or given really short notice of appointments and not able to make them, and they've been discharged because they haven't done so, and that's not appropriate.
Yeah, I think actually clear guidance about DNAs, even going
Mm.
deeper than this would be really, really helpful, because some clinics give patients, another chance to come. Some clinics, one strike and you're out, in terms of a DNA,
Which
which
is actually in breach of the NHS contract.
really,
So very
okay.
clearly,
Yeah.
if they
You say that.
miss one appointment and you discharge them from that, that is actually in breach of the NHS contract that is held with all specialty trusts. So by doing so, you are breaching your contract and absolutely liable for any fines that are appropriate from that perspective.
Mm. The next one's important. Arrange onward referrals without referring back to the GP to
Mhm.
do it for you. I sadly still see letters,
Yep.
asking for this sort of thing. I think secondary care become a little bit more wise to this being important. So now they sometimes use the word consider. They
Mhm.
sort of think, yeah, I think they do need to see this other speciality. This is my interpretation,
Yeah.
but they're not going to do it. So they say GP to consider, which effectively is the same thing sometimes.
Mhm.
So let's just be careful around that, secondary care colleagues.
Yeah.
Um, yeah, what do you think?
Please don't find workarounds just because you don't wanna do the work. It's my simple answer to some of those clinicians out there. But actually, majority of our colleagues in secondary care are actually very sensible. I'll point that out.
Yeah.
But there are some areas where this is clear cut. So particularly if it's within your own speciality, you need to do it. Okay? It is clear cut as that. If you are recommending tertiary services, for example, and stuff, and that is up to those clinicians to do. I'd argue if your patient's asking for a second opinion, that should also be done by that team. That should not be returned back to general practice to be doing and stuff, because actually that's got nothing to do with us. It's within your own department. Um, but even cross departments, if it's a clear cut, obvious thing that needs a referral. So, for example, the common one is 2 week waits. 2 week waits for cancer care should never be returned back to the GP to action. If you're a secondary care clinician doing that, you are wrong. There is no other way of describing that. You are wrong, and you're potentially risking patient harm by doing that. That should be an automatic process, and if you don't know that process, you need to find out that process within secondary care. Admittedly, a gastro consultant querying about a rash and stuff, returning that back to the practice to consider, does this need a dermatological input and stuff? Possibly, but again, remembering that general practice deals majority of stuff within general practice, so it may not need a referral. So indicate to the patient that this may be something to consider, but I'm returning it back to your GP to consider because it's something completely out of my specialty knowledge and stuff. So there is admittedly some grey areas. There's going to be, medicine is full of them, but also remembering about expectations and you don't know what other people can do.
Absolutely. So that's the last principle,
Mhm.
in this agreement. So it's the last chance for people to get their comments through to us, to let us know what they're thinking live about this. Any final conclusions, Gandhi, as we wrap up?
I think it's important to recognise that this is a principle. It's a consensus that they've come up with in terms of the Cheshire Merseyside area, and I think it's really, really good. I do think there's a couple of things missing. So, like I said, my perspective of patients being the vehicle of communication isn't included in this. Maybe actually, if they'd had direct patient involvement, which we don't know if they did or didn't, that may have come through in terms of an aspect and stuff. But I think this is easily something other areas can adapt and integrate into their principles. Again, remember, this is not a guideline. This is not a stick to beat your colleagues over the head with, but it's definitely a suggestion of appropriate things to start the discussions, to move those discussions forward, and to start looking at what do things look like in your local area from both sides of the table. Emphasis: this is not just me and you telling secondary care what they should be doing. Actually, there's a massive element of this that's on primary care as well. The biggest section was the principles for both and stuff.
Mm. I agree with everything you've said, and I guess I would just say I think this sync source. First of all, I applaud the work they've done to bring all the stakeholders together to have this conversation and produce the
Yep.
document. I think it sinks or swims based on how widely it is shared and how widely it is put into place. Will it be integrated into inductions in hospitals? Will GP registrars be required
Mhm.
reading around this? And will those people who lead their services support them to implement these principles? So time will tell, but I think it'd be great to see something in our local area. So that'd be fantastic.
Absolutely. And I think, if you want to share this with your colleagues, feel free to do so. It's our discussion and perspective on it and going into it in a little bit more detail. Alternately, you can share what's probably going to be coming up soon, which is a video about here that basically explains this document in really brief detail. So you can share that with your secretary colleagues, inductions, etc. Ultimately, YouTube's probably recommend something else for you right here. And as always, we're here to help tech and answer your primary care and learning. And we will catch you in the next episode. See you later.